the last time or not?
Yeah, we could do that. You want me to do
That
that?
yeah,
Yeah.
that will be better. One or two slides on that.
Okay,
Be
okay, okay.
terrific on that. है ना?
Sure, sure, sure.
So we are starting in three, two, one. So we are live now.
Good evening, friends, and welcome to the 24th edition of the PG Track program. And today we are having the second lecture in the series of hemodynamic assessment of the oximetry data, hemodynamics of the oximetry data. And we again have the privilege of having Dr. Ranjan Shetty with us. We have Professor Girish MP, Dr. Safal, and Dr. Sumod Kurian from GB Pant Hospital. And many of the residents have joined us as a panelist to solve all the questions. And I would request that all the fellows and residents who are interested, who are new, don't worry. These are simple things. You take a pen and paper and start solving all the questions one by one. It's a gradual learning process. So that is why we are having these repetitive programs and we are going very slow just for your benefit. So over to you, Dr. Sumod and Dr. Girish, to please start the session.
Yeah. Once again, welcome to this PG Track program. Thank you, Dr. Ranjan. As you have been listening to him, you would have realized that he's an excellent teacher who is able to teach. Come to our level, come to the students' level, and explain to us the hemodynamics so well. Last class, it was mainly about the theoretical part of the hemodynamics, but today, he has promised that it is going to be practical, how to go through each oximetry data and to interpret the data. So everyone is, I believe, is eager to listen to today's session. So we welcome Dr. Ranjan to come and present the
Yes. Thank you, Dr. Sumod. Thank you, Dr. Mohit, Dr. Girish. It's always a pleasure to be here. So I'm just going to recapitulate. Today, my job is very limited. I think it's more, I just have to put the slide and rest. Dr. Sumod, Dr. Mohit, and Dr. Girish will definitely take over. So just to recapitulate, step up is extremely important. We look at step up. So 7 at any level is considered significant. There are different definitions given by different people. So you could use 755, which is given in Grossman, or 966, which is given in Moss and Adams. So, it's important to know the diagnosis. Then simply, if you're just given numbers, because, it's like a spotter now, or you call it OSCE, people could ask you this, simple calculation. So you should know that QP by QS, it becomes little ulta, so saturation of iota minus mixed venous. We did discuss about mixed venous. Mixed venous could vary. It could be SVC, IVC, or it could be a chamber before this. What is also important is resistance. I think at the end of it, all of us agreed resistance is pressure divided by flow. And if it is, it's given in Wood's unit, and if you want to, you multiply to make it to body surface area, not divide. That's what we all agreed at the end. The other concept, I think, is when to use oxygen, when to use dissolved oxygen. If you give oxygen, make sure you use the dissolved oxygen, and that can be picked up by ABG. So these are some simple things which we went on. So remember, VO2 is given to you, but it is into meter square, and this is typically how the formula works. It's okay to bring it down if you're not using the dissolved oxygen. If you're using dissolved oxygen, PV, PA, SA, MV, all that has to be done separately. And we did go to the example. And also, as Dr. Girish was highlighting last time, it's very important for us to use our common sense. A same answer in a 1-year-old child to 7-year-old child to 30-year-old person may not be same. Step down, anything less than 95 is normal, but less than 92 is definitely step down. 2% will be considered step down. There are different areas of step down. Step up, even in your sleep, you should know the causes of step up, because this is the starting thing. People are going to give you this and ask some questions. So you need to know. Also remember, like low ASD leads to step up in ventricle. High VSD will lead to step up in the PA, and if you have PR or if you have TR for VSD TR, they will lead to step up in the previous chamber. With that, I think we did show these examples. So now I'm going to start with some example, and as we do example, guaranteed we'll discuss the concepts and understand cardiology itself. So with this question, I give this one to Dr. Sumod to choose a candidate and get a diagnosis.
Purneshwar, you will start looking at this data.
Now, in this oximetry, we can see that SVC saturation is 65 and RA is 70. So a step up of 5, but there is a significant step up from RA to RV. That is a step up of 24 in oxygen saturation. RV, PH saturations are the same, and LA, LV, and aorta saturations are the same. So there is a significant step up from the atria to ventricle. And on pressure data, we can see that the LV pressure is normal, FA pressure appears normal, and PA pressure also appears normal. And the RA mean pressure also appears normal, it's 4, and RV pressure is also normal. So
RV pressure is normal.
Sir, RV pressure, no sir, RV systolic pressure is systolic and diastolic both are high, sir. It's 66/44. So so a step up at the ventricular level, sir, so it can be a VSD with, since the RV saturation is 94, so it can be a left to right shunt.
Dr. Ranjan taught about linking the data. You need to link. So if RV of 66 systemic, how much PS systemic would you expect?
Sir, could not understand that question.
Pandey, RV
sir.
pressure is 66. Okay.
Yes, sir.
Now, what can be the reasons for this? That is number one.
Yes, sir.
RV is 66, LV is 140. So what is the amount of, he talked about different types of VSD, this according to the shunt, small shunt, large shunt, moderate size shunt or large shunt.
Okay, if somebody else want to try, Sai Sujana, you want to try? Sai
Ajayram?
Sir.
Yeah.
Sir, here we can see there is a systolic pressure gradient between RV to LV. The RV pressure is almost greater than 1/3, but is less than 2/3, sir. So it's most likely a moderate sized VSD. We can see moderate sized VSD along with some amount of PS can also be seen because of pressure gradient between the RV and pulmonary artery, systolic pressure gradient between RV and pulmonary artery. And there is, we can calculate, that is the one which we can calculate the QP by QS. We can differentiate whether it is a large shunt with moderate size VSD along with some amount of PS. Maybe pulmonary stenosis can be seen. Along with LV, we can see a wide pulse pressure of 140/15, maybe associated AR is also present for these patients.
No, for AR, you don't look at LV, you look at aorta.
Yes. Okay.
So I think we agree that it is a moderate VSD because the pressure is moderate. RV pressure and LV pressure decides the VSD is decided by the VSD size. Definitely there is a significant step up, no? So shunt is definitely 2:1, but last class itself we discussed size and shunt may not match each other. And there is a PS. Now there is one interesting question. What would be can VSD itself produce a gradient? Like, ASD produces a gradient across pulmonary sometime, no? So is it just the flow which is producing the gradient, or do you think there is an organic stenosis? Now, RV part we have sorted out. RV, LV part, I think we have sorted out. It's all decided by the VSD. No? Not by the PS, but we decided by the PSD. But the problem here is the PA pressure is low. So is it TOF? That is the first question. Is it TOF?
So in TOF, at least the RV pressure will be equal to LV, no, sir.
Correct. Because the VSD is non-restrictive, no?
Non-restrictive.
Non-restrictive, so the RV is equal to LV. You don't see that here. So what's happening here?
So only VSD with PS.
Sir, it can be a Hoffman variant with a muscular VSD with PS.
The Hoffman variant of a TOF, no?
Yes, sir.
Yeah, but in Hoffman variant, Dr. Sumod will definitely answer this for you. The pressure RV becomes suprasystemic.
Suprasystemic.
It doesn't go subsystemic. Okay.
Yes, sir. Yes.
Hoffman is other way. RV more than LV, and and in a cyanotic heart disease. Do you see any desaturation anywhere?
No, sir. No, sir. There
Yeah,
is
so
no
you have
difference.
saturation data, and you know that VSD is not large VSD. It was definitely not a top or top subgroup, but there is PS. But remember one thing, sometime in ASD and also VSD, you can have gradient across the pulmonary valve because of the flow. As per Moss and Adams, the gradient could be up to 70 in ASD and up to 40 is common. But whenever you have flow related increased gradient, the mean PA also rises. Okay, the mean PA rises. In them, the mean will be 24, 25, 30. So here with the normal mean RV pressure, which is different from PA, indicates there is a PS here. Okay, pulmonary stenosis. Any doubts here? But Sumod, you would like to add anything?
Yeah, VST generally produces left-sided gradients to increase more than producing enough.
Right-sided, yes.
Okay, Pandey, what is Gasul's anomaly? Gasul's phenomenon?
Anybody would like to answer? What is Gasul's?
You call it na acquired PS at sub valvular level.
Yeah, like this patient could have this thing. Initial echo would have shown only a VST, but over follow-up you will see that RV, the RV muscle get hypertrophied and producing a RVOT obstruction, which is also called as Gasul's
phenomenon. Okay. It's an interesting phenomenon, no, Dr. Sumod? Yeah. People also talk. I mean, we are discussing about Gasul. People also talk about the PA RV angle is supposed to be abnormal in Gazuls. So it's more like TOF than like a valvular PS. So do you agree with that, Dr. Sumod? That PA angle, no, the direction of the PA bends. TOF it bends a lot, whereas normal PA is like this. They say in Gazuls it is already bent. That means they were predetermined to be Gazuls, not it's acquired, but they're predetermined to be acquired. Yeah, that's what. Yeah. So the next question I'm going to put. So it is VSD left to right with right ventricular outflow. Do not call it PS because you don't know the level of PS. So better to use term RVOTO. So we're going to put the next question, and Dr. Sumod is going to take over.
Deepanjan, you want to attempt this?
Yes, this is showing step up of 5% from the SVC to the RA, which is not, like mild step up. There is a significant step up from the RA to the RV of like 7%, and then after that, there is no step up from RV to PA. The systemic saturation is like normal. The RV pressure is normal with no gradient from RV to PA. There is no significant gradient between the LV and the aorta, or the aorta and the femoral artery. So there is a step up from RA to RV, which shows there's a left to right shunt from probably at the atrial wall level, and it is restrictive because the RA and LA pressures are not similar.
Deepanjan, why aortic pressure is having a low diastolic pressure?
Sir, aortic. There's a wide pulse pressure in the aorta, which can aortic regurgitation may be there probably.
So your differential diagnosis is VST with AR?
So ASD.
What is your differential diagnosis, Bado? You want to say the diagnosis?
Yes, it's like VSD with AR.
Okay, VST with AR. Any other possibilities?
One situation probably which will explain both your findings.
Yeah, if you have to give one diagnosis, what would it be? If it is two diagnoses, yes, VSD AR.
We told now what are the causes of step up of RV.
Yeah, could you just recall the causes of step up in RV apart from VSD?
Sir, RSOV to the right ventricle, that may be a cause. Then coronary cameral fistula from the to the RV. So coronary cameral fistula can also be a cause in this case. This is causing a diastolic runoff from the aorta into the RV.
It's
What
not
about-
wrong, but still there is a more obvious diagnosis. I mean, more obvious would be RSOV to RV, no?
Yes, sir.
Yeah, because that's commoner, and it's more obvious diagnosis. At this point, they could ask you in exam the difference between RSOV to RV, RSOV to RA, 3-4 differences. So
Okay, sir.
we did discuss sometime which will have a prominent A wave in JVP.
Prominent A wave, RSOV to RV, because the RV pressure will be elevated, the atrium will have to pump more.
Correct. And if the V wave is it?
Then it is
when it is shifted
to RA.
RA. Okay. So these are some small things. Sometimes the slides which are given are, it's a window to lots of other questions. So make sure once RSO is asked, you read a lot. Okay.
Okay, sir.
So yeah. VSD significant AR or RSOV, both are possible. Okay. The next one.
Dr. Rajveer, you want to say?
Anyone else?
Hi,
Ajay,
Sujana. Hi.
Acha, Sudhir is there. Sudhir, are you ready to take up this?
Yes.
Take time and analyze and then speak rather than rushing everybody. These are all learning exercises, so don't get disheartened by strong messages. Just go relaxed and easy with this.
see my
Femoral artery saturation is
Sudhir, how would I initiate my analysis is first look at the systemic artery saturation. You will come
Yeah.
to know whether it is cyanotic or acyanotic.
Yes.
Second, look at SVC. If SVC is not very much desaturated, that means you are not dealing with a child or a person who is grossly, relatively stable. Okay, then you go on to other interpretations.
yes. Sir, here in this case, femoral artery saturation is normal. So we are dealing with a acyanotic case, and SVC saturation is 70%. So the cardiac reserve is okay, sir. High right atrium saturation is 72, and there is a step up from high right atrium to right atrium of 8%, sir. Lower right atrium had saturation 84%, with further increase of step up of 4%, sir. So within atrium from SVC to lower right atrium, there is increase of 14%, sir. 14% step up in oxygen saturation. Further in saturation data, there is no step up from RA to RV or PA, sir. Left side saturation seems to be okay, sir. In pressure data, sir, RA mean pressure is elevated. RV systolic pressure is elevated, sir.
No. First and foremost, see, Sudhir,
Yes, sir.
you have a step up at RA, right? The most common causes
ASD, sir.
ASD. The first thing you look in pressure is RA and LA.
RA and LS.
You should expect that both should be same.
Same if there is no.
If there is some discrepancy, then you'll have to think over. You'll have to go stepwise. You analyze things, what comes to your mind first, then you should see first, and then you should start seeing other things.
Yes. So RA mean pressure is 14 and LA mean pressure is 10, sir.
So
What do you think? Is there a
what is
ASD?
ruled out?
It could be, sir, PA-PVC also, sir.
But yeah, where is the PAPVC
Yeah.
joining?
Yeah.
Where does it commonly join? PAPVCs.
Yeah. In this, sir, it seems like it is joining in because the step up is like in the lower right atrium. So this connection seems to be from into the coronary sinus, maybe, which is draining into the lower right atrium.
Yes, there are many possibilities. That's That's one. Anything else? Yeah. Yeah, this is the whole point, as I think everybody is
Since
saying is
the
yeah.
pressure between LA and RA, sir, because like the mean RA pressure is like around 14 and mean LA pressure is 10 only. So like if it is like because significant step up is there, so like for significant step up, there should be at least equalization of either pressure or at least LA pressure should be at least high. So it seems something not other than ASD, something is there, like.
Correct. So there is step up of atria, and it's very likely other than ASD. Anything else is possible. So think of all the causes, see which are very likely to produce some increase in RV pressure, some increase in RA pressure, more step up in lower atrium.
Internally, VSDs are directed to the RS.
Yes. No, the V is high. See, look at that mean and V of this one. So VSD-TR is also a possibility, no? RV pressure is elevated. Just if it is just a flow, you don't expect RV to be elevated, no?
Yes, sir.
If it is ASD, you don't expect RV to be elevated. Hardly anyway RV will be elevated. Sometimes rarely a flow can elevate up to 30, 40, but here it is 64. We also know there is a torrential shunt which is left to right. So very likely that it is a VSD TR, no?
Yes, sir.
Okay. What about Gerbaud defect?
Yes.
LV2R.
Yes, Gerbaud is definitely possible. Again, maybe what is little odd is the elevated RV pressure, because Gerbaud is typically LV without changes in pulmonary vasculature. But otherwise, yes, Gerbaud also is possible. Remember Gerbaud whenever you think of step up in RA. The next, the ninth one.
Sai is there? No. Okay. Kamlesh?
Yeah, yes. So proceeding with the same, like femoral artery saturation is 98, so it seems some acyanotic heart disease only. And like coming to SVC, it is 70, RA is 70, same, no step up at RV, PA is 84. So significant step up at the level of PA. And coming to the pressure, RA pressure is 4, RV is 46/6. Okay, PA is 23. So step up at pulmonary artery level, and pulmonary artery pressure is equal to RV.
Okay, first tell causes of step up at PA.
PA level, yeah.
All causes step up?
At pulmonary artery, yeah. Causes of step up at PA.
Could be PDA, sir, also, but pressure.
What is against PDA?
The pressure should be high in pulmonary arteries, sir, at least.
What
Compared
decides
to
the
RV.
pressure?
White pulse pressure. White pulse pressure you guys.
Pressure is decided by the size, no? So it's not a large PDA. It's not a PDA as big as aorta, descending aorta. You know, for PDA we take descending aorta and PA. For VSD we take ascending aorta, or that area, because that's the next chamber where it goes. So it's not a big PDA, but can it be a moderate PDA? Or a
Yes, sir.
small PDA with a little large shunt?
Yes, sir.
PDA, any significant shunt is there means you expect a wide pulse pressure. You get bounding pulses and wide pulse pressure. So PDA without with this kind of pulse pressure will be little low down.
Very good.
What else can produce apart from PDA? What else can produce step up in PA? Nothing else. Sudhir?
Sir, AP window or outlet VSD.
AP window.
Yes, Dhanji.
Yes, sir. AP window or outlet VSD.
Anything else? There must be at least, you need to know 5-6 causes. Even in your sleep, you should be able to tell 6 causes.
Shunt lesion also, like.
Which shunt?
iatrogenic shunt, if like pulmonary artery, previously like BT shunt, now modified one is like attached.
Correct. Surgical shunt, no? Surgical iotoPA shunts. Yes. Then what else? Can RSOV go to PA?
Okay.
Again, if in the outflow, you may not get because RV saturations are generally measured in the RV body, so may not measure in there. So you may get a step up only in PA.
Okay, sir.
Yes. Outlet VSD and RSOV to PA is also possible. You can also have coronary fistula to PA. That's common actually. We do see that. So let's see the answer. So all of them are possible. Please remember that. So the main thing is step up. Now I have a question for you. If it is a PDA, how do you calculate the resistance? Is there I know you don't have to do it, but you need to know the answer. So if there is PDA, see PDA typically shunts to left side, LPA. So you're not really getting there is no uniform chamber to really look at step up. So if it is PDA, how would you calculate the pulmonary vascular resistance? Who will answer? Ajay will answer, or is there a different formula? If you know. So imagine in a PDAC, right side saturation was 72 and LPA saturation was 84 and MPA saturation was in between. We assume that PA saturation is uniform across PA. It's not true with PDA. PDA selectively goes to LPA. So LPA beyond the shunt saturation versus RPA saturation is not same. So there's no mixing chamber in PDA. So if you have to calculate PVR, how will you calculate? This is what I wanted to cover in theory, but I thought it's better with examples so that they understand. Any of them? How do you add resistances? Anybody who wanted to become an engineer and ended up becoming a cardiologist? Yeah. Ajay, yes.
I don't know. Mostly we have to take more saturation distally, sir. I think in distal saturation.
Yeah, distal LPA you can take, but RPA will be different, no?
Either we take average, I think.
Yeah, average is what most people do, and maybe in cath lab we also do. But ideally, you are supposed to do VO2 divided by 2, calculate separate resistance for right lung, calculate separate resistance for left lung. Okay, half. Then 1 by R is equal to 1 by R1 plus 1 by R2. Resistance is calculated by by reciprocal, you have to add. So this could be a question for you whenever there is a differential problem. Can occur in some cyanotic like hemitruncus and things like that, where there is one circulation totally behaving different from the other circulation. You may have to do this formula 1 by R. I don't know whether you will do it, but please know the formula so that you'll know to say it. Okay.
Okay, sir.
Question number 10. So, we are going systematic so that you understand a little bit about the subject also and ask your questions.
Okay, Puneshwar, again, Puneshwar.
Yes, sir. Here we can see that the femoral artery saturation is 88. So we might be dealing with a cyanotic condition, and the SVC saturation is 88 and IVC saturation is 66. Then RA saturation and RV saturation are the same. So there is
Actually,
no
all saturations are
all
same.
saturations are the same. Yes, sir.
So
all the chambers are the same.
One person only, one person. Yeah.
It seems supracardiac TAPVC, sir.
Yes, it's admixture lesion, supracardiac, no, because near equalization of all saturation. That's very characteristic of admixture lesion. So whenever you talk about admixture region, first thing you have to pick up admixture region. So basically iota and RA will have almost, iota and PA will have same saturation, but admixture chamber could vary. In this case, it will be SVC or RA, that is admixture at atrial level. You could have condition with admixture at ventricular level like single ventricle or DORV. You could have admixture at atrial level like single atria, tricuspid atresia, or more classically it is TAPVC. Admixture at great artery level will actually be truncus arteriosus. So there are many admixture lesions which are possible. So here it is looks like admixture chamber at SVC. What else can you make out in this case? Is there anything more? What else should you see? Now that you know it is TAPVC and it is supracardiac TAPVC, you have to answer 2-3 questions. Is it obstructed or not obstructed? What are the levels of obstruction? From the information which you have, what would you do?
Is the pH?
Yes, there is some pH. What do you think is the cause? Is it because of obstruction or is it because of the flow? Or is it PS? Or is it problem with the interatrial septum? What are the levels of obstruction in TAPVC? So if you'll answer fast, I think all of us can ask you 2-3 other questions like a quick fire, rapid fire. Like why is intracardiac TAPVC always obstructed and things like that. Yeah. But Sumodh is eager to ask you. Yeah.
Ajay, want to answer? Ajay?
Yeah. I think it is a non-obstructed. It is not obstructed because the RA and LA pressures are equal only.
Okay. RA LA equal means only one thing here, that atrial communication is not obstructed. Okay, that also is a cause of obstruction, atrial communication. If there is a PFO, then that leads to PAH, and atria, left atria is at mercy of right atria in this condition. Unlike other condition, RA will be higher than LA. So atrial level obstruction you are not seeing. Why do you think there is PAH?
See, maybe it may be flow related, sir, because
could be. I agree with you. It could be flow related because the
mean is elevated.
Yes, the mean PA is also elevated.
Mean is also elevated.
Yes, and the difference between RV and PA is just 15. Okay. Now admixture is something which you should do. Okay. Yeah. I'm going to ask you one more question here. Which TAPVC has favorable streaming? Intracardiac or supracardiac? I'm not asking favorable prognosis. I'm only asking favorable streaming. For that, you should know what is streaming and how does it occur.
The flow of blood will be directed towards, for example, in infracardiac TAPVC, the flow of blood is directed, the IVC, eustachian wall, the blood is flowed towards the LA, sir. It is favorable streaming in infracardiac type.
Correct. Strange, although the prognosis is bad, most of the time it's obstructed. The streaming is actually favorable in intracardiac TAPVC than supracardiac TAPVC. Okay, but non-obstructed through supracardiac has better prognosis. So streaming means where the venous return, the systemic venous return directed towards PA and pulmonary venous return directed towards aorta. That's what is streaming. It's favorable if systemic is directed towards PA. If it is unfavorable, if systemic is directed towards aorta. That's how you go, favorable streaming and unfavorable. Please read admixture. That's a very interesting and important topic. When you finish cardiology, you should be master in that. Okay.
Sir, this infracardiac TAPVC, mostly the obstruction at the level of the connection to portal vein and to IVC actually.
Yes, so the intracardiac is always obstructed. That is a rule. Reason being, the obstruction could be when it goes into diaphragm. Whatever, even if there is no obstruction there, it has to pass through hepatic sinusoids. Once the ductus venosus closes, the most common site it will go to left portal vein. But once ductus venosus closes, it will have to go to liver sinusoids. That's the capillaries. Capillaries will raise the pressure. Okay. So intracardiac is almost always obstructed.
So with this data, sir, can we say, sir, like where is the obstruction or like that?
Yeah, here what you can say it is supracardiac TAPVC, no atrial level obstruction. There is PAH, but most likely it is because of the flow. So it's very likely unobstructed TAPVC.
Okay, sir.
The next one.
Debanjan, you can read it.
Yes, the systemic saturation is less, so we are dealing with a cyanotic heart disease. And we see that there is not much step between the IVC and the RA. Almost the RA, RV, and PS saturations are similar. The left-sided pressures, the pulmonary venous pressure is 84. Between the pulmonary arterial wedge and the pulmonary vein, there is a significant step down. And there is the saturations of the pulmonary vein, LA, LV, are almost like same, with a step down between from LV to aorta to femoral artery.
What do you think is the problem then?
Their right to left shunting is working at the level of the pulmonary veins, as well as the aorta or the PDA. There's a PDA which is shunting from right to left, which is causing a step down from the aorta to the femoral artery.
No, see, for PDA to shunt right
No,
to
no,
left,
no.
the PA pressure should be high, no?
Yes, sir. The PA pressures are
Unless
not
the
high.
PA pressure is high,
Yes, sir.
it's not going to shunt right to left. So it's not the PDA.
Systemic-
What's happening is there is a pulmonary venous desaturation, no doubt. Now, what
Yes,
would be
sir.
the causes for pulmonary venous desaturation?
Sir, any communication between the pulmonary artery and the pulmonary
Vein, that will be pulmonary AVM. Is there
Yes, sir.
any other possibility?
Systemic to pulmonary vein connection.
Systemic to pulmonary is
veins.
left to right shunt,
That is
not right to left.
Systemic vein to pulmonary vein. Like if there's a
Systemic vein to pulmonary vein. That's
Very
very
rare.
unusual. I have not seen one. Dr. Sumod, you must have seen. Systemic vein to pulmonary vein is very unusual. Have you seen? I've seen systemic artery to pulmonary vein, and we closed it with the PDA device. The child was in this one. But yeah, more common is systemic vein to LA, you know. LSVC to LA opening is possible, definitely, either deroofing or direct. Lung disease itself, remember, lung disease also can produce a pulmonary venous desaturation. Imagine this is ILD, lung is not getting saturated. So pulmonary veins rule out lung disease, or it is pulmonary AVM. For AVM, you know, all veins involvement is unusual. So you have to separately take different veins. One more question which is asked here is, which is the right to left, which is the left to right shunt where flow across all four valve is same, and which is the right to left shunt where flow across all four valve is same? So this is one question which is asked to you. So what are the answers for these? Different answer, yeah. Dipanjan, you can answer, yeah. Right to left with flow across all four, left to right with the flow across all four valves, same flow.
same. TAPVC can.
Now TAPVC, the flow across the mitral and tricuspid are not same, no?
Same.
Mitral
Yes,
is lower, tricuspid is higher.
Is higher.
The TAPVC, no.
No, sir, I don't know this answer.
Anybody else wants to try? So Dan, yeah, Ajay, you're trying, yeah.
Right. So left to right shunt with equal flow in all the chambers. Huh?
Four valves, yeah.
And similarly, right to left.
Answer?
Maybe RSOV to RA, that is.
Correct. RSOV to RA, because once it is RA, all the four valves will have same flow. Now the other question, right to left with same flow across all four valves.
Maybe tricuspid atresia.
No.
No.
There's no flow across tricuspid valve at all, no?
Okay. Flow should be there.
Flow should be same, yeah. Answer is on the screen, yeah.
Okay, AVM.
Pulmonary AVM, because the flow doesn't change, no? Flow across PA, flow across aorta, all of the shunt is beyond that. So flow is same. So right to left. This is one question which will be asked. But remember, it could be lung disease also if you have something like this, unless you know all the four AVM. Okay. Next question.
Sir, one doubt. What caused the? Sir, there's one doubt. What caused the fall in saturation from the LV to the aorta to the femoral artery?
It's almost the same because it's already 79, 74. So, you know, it definitely not a PDA. It's for you to think.
Okay, sir.
If you talk about PDA, PA pressure should be suprasystemic.
Yes, sir.
Or systemic, or there should be coarctation. Okay.
Okay, sir.
If there is coarct, even lower pressure can shunt. Otherwise, no.
Okay, sir.
Dr. Smooth, you were saying something?
No, actually, pulmonary wedge saturation will be a little confusing. How did we 98 versus really
Yeah. Wedge, wedge should be typically 100. Maybe that's the way to rule out pulmonary disease. No, that is the way, because the wedge is normal, ILD is unlikely. Yeah.
Okay, Kamlesh.
This also, sir, seems initially because femoral artery saturation is 74 to seem some cyanotic heart disease, but we see this step down occurring at the level of LA. So, but here pulmonary artery wedge pressure, the saturation and PV saturation equally same, and then a significant step down at LA. So it is seems identical to the previous cases like pulmonary AB.
Yeah, but pulmonary vein is normal here. Very identical numbers so that you know what we are dealing, so that you understand the concept. But pulmonary vein is normal here. Imagine they have taken 2 pulmonary veins. You know, you have to take 2 and both were normal. But when they took LA is low.
And all pressure, cause of cyanosis with normal PA pressure, you know?
Yes.
What are the
Actually, the last one you think of once you rule out everything.
Oh, you need only Dr. Sumot to do the echo and pick it up. More normal, otherwise it will be normal echo. Yeah.
Pressure also seems normal only, sir, across all chamber.
But such deep cyanosis, no? So we need to find a cause.
The cause was mentioned just before also.
Yes, somebody mentioned it for that answer, but it's right for this question.
Rupture RSOV.
It's left to right. It's never right to left. No, that is one thing which doesn't Eisenmengerize.
Like there are anomalous connections in right side. Can there be anomalous connection in the left side?
LSVC to LA.
Correct. Who told? Yeah, somebody answered it. No. So LSVC to LA or unroofing of the coronary sinus. LSV to CS with unroofing. LSV to both are possible, and that is what we consider when this. So this is cyanosis with structurally normal heart. Also, one tip, whenever you do a bubble contrast echo, put a IV line on left arm. You'll be surprised. Sometime you'll pick up LSVC, LSVC to LA. As much as possible, bubble contrast, try to do it in the left arm. So this is the answer. Systemic venous to LA drainage. Yeah, very rarely IVC also can produce. It's not always SVC, but it's uncommon. SVC is very, very common. Any doubts here? Can we go to the next one? Yeah, next one.
Okay, Sai, you want to try? Sai? If Sai is not there, Sudhir?
Similar numbers, but not the same case. Yeah.
Femoral saturation is less, so we are dealing with a cyanotic heart disease case. SVC saturation is okay.
Yeah, Girish told, also whenever you get, last time Legend also told that when you get a FA desaturation, always look at the pulmonary vein saturation, LS saturation also. Then also we'll get a clue what is the, because it's a lung disease versus, so, okay, continue.
Saturation, see the pressures.
RA pressure is high, mean pressure is high. RV pressure is also high, sir. And PA pressure seems to be normal, sir. So there is some obstructive lesion from RV to PA in RVOT obstruction, sir.
So RVT obstruction. So how will you explain the desaturation?
What is the level of desaturation and what is causing it?
Can severe RVT obstruction produce in the
Trilogy
absence
of
of VSD?
trilogy.
Sir, in a severe PS, critical PS, there will be RARV failure with right to left shunt through the PFO. That would be the cause here to maintain a systemic desaturation.
Okay. So here there is a desaturation at LA level. No, not
Yes,
at
sir.
LV level, but LA level. So that means there is a right to left shunt at
PFO.
LA level. The
Most
reason there is
PFO.
severe PS and elevated RA pressure. That means there is some sort of RV dysfunction also. Otherwise, why should RA rise? When RA raises and then there is a shunt to right to left, what is it likely? Is it ASD or is it PFO? So there is a atrial level right to left. So is it because of PS ASD or is it because of PS PFO? How do you distinguish them clinically and by this? How do when does PS ASD shunt? When does PS PFO shunt?
Yes.
And Dr. Mohit is, Professor
Sir,
Mohit was
here-
telling, don't worry, just try. It's okay.
Here the PA pressure is most likely normal, sir. But in ASD Eisenmengerization, we can see the mean pressure of PA will also.
No,
be
question is
elevated.
not Eisenmengerization. There is PS, but
Yes,
there
sir.
is shunt at atrial level. Now this could occur with PS ASD or PS PFO, no?
Yes, sir. Yes, sir.
Opening of a PFO. So how do you distinguish these two? We know there is PS here, we know there is atrial shunt. Do you think it's ASD or PFO in this case?
RA-LA pressures, significant difference is there, sir.
Yes. So what is it likely?
PFO is likely.
PS PFO. When RV fails, PFO shunts. Okay. Even clinically, this is one case which, see, in adult cyanosis, there are 3 or 4 causes. No, all of you know about Eisenmenger and TOF. Other 2 causes are also important. The other 2 causes, one is Epstein and third is PS PFO or PS ASD. Okay. So PS ASD will shunt much earlier because ASD shunt is decided by RV compliance versus LV compliance. As RV becomes thick, RV compliance comes down, the shunting occurs quicker, especially exertional mild cyanosis occur quicker. But PS PFO occurs only when RV fails, systolic or diastolic. So RA pressure has to rise. So going by this example, this is PS PFO. Okay. Any doubt?
Sir, I would like to, ask you to repeat it. I could not understand the difference between PS,
Okay,
ASD, and PFO.
Dr. Sudhir? Huh?
Dr. Pandey.
Sir,
Dr. Pandey,
in
please.
PS, there should be some gradient, no, sir, like from
RV to PA.
RV to PA.
Yeah, look at the gradient here, 208 and 28.
Yes, it's a very high gradient.
There's 200 gradient actually. There's a very severe gradient. Ventricular septum is intact because otherwise the aortic pressure, desaturation would be RV level or aortic pressure would have been equal to LV pressure. So intact ventricular septum. Look at the RA pressure. Desaturation is at LA level. There is no doubt. No, LA there is desaturation. But RA is 16, LA is 6. That means there is no ASD. ASD would have equalized RA and LA pressure. No, but there is desaturation at LA level. That means it is PS PFO. PFO, the flap stretches. When RV fails, when RA dilates, the flap stretches. RA pressure remains high and it shunts to right to left. PFO, the shunt, the size of shunting is 3 or 4 millimeter. No, it's not huge. The magnitude of shunt may be more, but the size of shunt is not much. Moment size of shunt is not much. There is pressure gradient between RA and LA. So that is PS PFO. Clinically also, if there is a case of PS, severe PS, typically valvular, RVH is too much. When they develop cyanosis, if it is ASD, the cyanosis occurs early because RV compliance decreases. ASD, the determinant of shunt is RV compliance versus LV compliance. So if there is ASD, the shunting occurs early. If there is PFO, shunting occurs only with failure. Do you agree, Dr. Sumodh? You can, maybe there are lots of questions about that. You can maybe explain once.
No, I think you
this
explained very well. Yeah.
cannot we explain these things, sir, with ASD, sir? Like why, like PFO, sir? Like this
With what? VSD,
PS, this with ASD only, yes, sir.
No, ASD,
LA
RA
and
and LA
RA
pressure should be equal, no?
Okay, sir.
RA, LA pressure should be equal if it is ASD.
No,
Size
but-
decides. So either it's a restrictive ASD or PFO, okay?
Okay, sir.
That's why. Otherwise, RA, LA pressure should have been equal. So when a chart is given to you,
Okay.
definitely
Even
it's
sir, like
artificial.
in
somebody
Eisenmengerization, I'm asking, like, sir, even in Eisenmengerization also, like if ASD is there, and because of ASD or anything, if ASD is there, like RA LV pressure will be equal, sir. If ASD is there.
Yeah.
No?
If ASD is there, RA LV is pressure. It's not decided by shunt is this side or that side. Same thing with VSD Eisenmenger also. LA, RV and LV. Size itself decides the pressure. Not shunt
Sir,
this way, that way.
one small doubt, sir. Like this PS, if it is there, like RV to PA, there should be a step up of gradient. I'm wrong or what? Like,
No step up. There should be only gradient.
Okay.
See, severe PS, there is no pulmonary oligemia.
Previous thing we discussed, like in which PS was there and like pulmonary artery pressure was high and RV pressure was small. So there was gradient, no, sir. So
Yeah, but there was a left to right shunt there. The left to right shunt itself can produce will produce step up and also will produce flow dependent gradient.
Okay, sir.
Because of the flow. Here there is no left to right. Here it is right to left.
Mm-hmm.
The flow itself can produce some gradient, like hyperkinetic pH you call, no, clinically.
Yeah.
Hyperkinetic pH is flow directed pH, gradient.
We can go on.
So basically this is PS with restrictive ASD, right, sir?
Yeah, or PFO. PS with atrial level shunt, right to left. That's the right answer. Very likely PFO. Okay,
sir.
Next one. Yeah.
Bhuvneshwar, next one.
Yes, sir. Hello.
Yes.
Yeah, the femoral artery saturation is 86. So we are dealing with a desaturation, so cyanotic conditions. There is a significant step down from LA to LV, and in SVC RA saturation, there is a significant step up from RA to RV, that is around 20, and there is a significant step down from LA to LV. Then the pressure data, the RA pressure seems okay. The RV pressure is high. The PA pressure is okay, and LV and aortic pressure seems normal.
You should not only look PA pressure is okay, PA pressure is correlating with the RV pressure also, you should see. With 114 RV pressure, PA pressure is correlating.
No, sir. PA pressure, there is a gradient between RV and PA.
This is top with a non-restrictive VSD.
Okay, but what is odd? See, there is VSD, there is PD, there is PS, there is non-restrictive VSD. What is odd for odd?
Odd.
Is it all fine or?
How do you explain the step up?
Yeah, RV step up is little confusing, no? What do you think is producing it?
So like this LV and RV saturation is almost equal only, no, sir?
So you think it is a single ventricle? No, yeah, when you use TOF also, there is one more word. See, TOF means right to left shunt. But you have evidence of? You also have evidence of left to right shunt, no?
Yes.
Yes, sir.
So there is VSD, there is bidirectional shunt, and there is PS. Okay, non-restrictive
Yes,
VSD, bidirectional shunt, PS. So yes, it is very likely TOF, but will it be a severe TOF or a milder TOF? Again, I'm repeating, I think, what don't worry. You know, finally, what Dr. Mohit is told you again and again, don't get panicked. Number of variables are limited. I'm sure the same examples will keep coming. So don't worry, just try it and make a diagnosis. But remember, these are not real values, no? So people have thought about it and made a value so that you understand what's going around. Okay. So also, you know, that's the beauty of hemodynamics, where you understand more than just VSD, ASD. You know, you also know the disease very well. So who is answering, Dr. Kamlesh? Is it likely to be a milder TOF or a severe TOF?
Sir, if like PS will see like because pulmonary artery pressure is mean is 8 only. So PS is like severe only, sir.
Yeah, see,
but
one
like
thing
TOF,
in TOF
we
with
cannot.
Dr. Sumodh will teach you in ECO, the gradient across RV to PA in TOF does not matter. Whether it's mild or severe, the gradient will be almost same because RV pressure is decided by the VSD, no?
Yes, sir. Yes, sir.
If at all the stenosis is more severe, there will be more right to left shunt. If the stenosis is less severe, there will be less right to left shunt, and there will be some left to right shunt. So this is likely to be a milder TOF. Okay. If it was a severe TOF, no, the chance of left to right shunt is much lesser. It will become predominantly right to left. But PA and RV gradient is almost always high in TOF because ventricle now has two outlets. It can choose to go to PA or it could choose to come to LV. Is it okay, Dr. Who answered? I don't know, but did you follow this?
Yeah, like only thing which I like thinking like RV pressure is 140 na, and
Yes.
LV pressure is 104. So it is like suprasystemic pressure.
Yeah, we
and the
don't
gradient,
give so much value. Yeah, if it is around this range, we don't give so much value because there is definitely a left to right shunt also happening. So it is definitely a large VSD which is nearly equalizing both pressure. So do not give too much value. If it is around 10 or little less than 10, don't give too much value. Okay.
No, just I'm asking, sir, like in a TOF, like is there any shunt or like just because shunt is right to actually aorta, no, sir, like right to.
Yeah,
so
shunt in
like,
TOF is predominantly right to left, but magnitude of right to left shunt is decided by severity of PS. Okay.
no, why we are talking here left to right, sir? That's why.
Because there is step up at RV.
RV level.
The example shows step up at RV, no? And you need to explain why why there is step up at RV. So that means the same VSD which is producing right to left is also producing left to right. So there is evidence for bidirectional shunt. And also there is evidence for PS, no?
Okay, okay.
Pulmonary stenosis. So it's likely to be a non-restrictive VSD with PS. So it's a TOF physiology. But among TOF, this is likely to be a milder TOF. Why is it milder? Because it's also allowing some amount of left to right shunt along with right to left shunt. Do you agree, Dr. Mohit?
Yeah, that's perfect. We can go on to the next one.
Dr. Sumodh, anything to add on? Yeah.
Single ventricle with PS. There is some generally we think that TOF you will get step down from LV to aorta.
Yes.
LV will get a borderline kind of a saturation in between kind of thing, and then most of the discharge will be at the aorta.
It's aorta, yes.
Or like a admixture like 86, 84, almost similar aorta PA. Single ventricle PS also should be okay.
Yes, I agree. Only thing is they purposely mentioned a different RV pressure and LV pressure, probably just to avoid that, that was mentioned differently just to avoid that confusion. But single ventricle could actually have exactly the same thing. Yeah. One more question just for you to understand. So, this also message for all of you to please read congenital heart disease very thoroughly and understand the concepts very thoroughly. It's not as simple, little more depth is what we need in cardiology. So my question to all of you is, which TOF has the best natural history? among 7 types of TOF, Purneshwar we can ask, I think. Among 7 types of TOF, which TOF has the best natural history?
Basically, differential diagnosis of TOF. TOF
Yes,
physiology.
among all the
TOF
7
physiology.
differentials.
physiology.
Yes.
Top physiology.
Top physiology. Yeah.
Yes, among TOF physiology. Yes, yes. I'll make it easy. It's not classical TOF.
At least one of you can name them so that you know what to think about. Right? Who want to name? Ajay want to name? The 7 TOF physiologies?
TOF with VSDPS,
No,
DORV
no.
with VSDPS.
Okay.
Sir.
Okay.
No, sir. आपने 7 variants.
Yes,
Basically, all the differentials of TOF. That is what Dr. Samodi is asking.
TOF with VSDPS, DORV with VSDPS, TGA with VSDPS, then single ventricle or any triology of Faraday AST with PS with RVH. And
Triology is not a TOF physiology. No? Triology is totally different.
Triology was the last case which we discussed.
This one VSD, only VSD with PS also.
All CT,
2 more you have to
British,
say.
yeah, so many.
Yes, sir. But the tricuspid attrition. Oh, yes.
Again, Ajayram, you said TOF
sir.
with VSDPS. Is there any TOF without VSDPS?
No, sir.
So TOF by
It will be
definition
the,
is
it is
VSDPS.
a part of TOF,
Yes.
only TOF. Okay, sir.
So just tell tetralogy of fellow.
Okay.
I think 2 you missed, no? I didn't hear you say. Most of them you said, but I think 2 you missed.
CTGA, ABST, all this thing you should say.
Yes, yes, yes. And I didn't hear tricuspid atresia. I don't know whether he has told it.
You're not told.
So which has the best natural history now, Ajay?
CCTG with VSDPS will have.
No.
I think.
Actually, single ventricle VSDPS, single ventricle PS, there's no VSD. The single ventricle PS is the best because that ventricle is very likely LV, no? More likely the single ventricles are LV than RV, and LV as a systemic ventricle fares better than RV as a systemic ventricle. So let's see the answer with non-restrictive VSD, but the key discussion is about bidirectionality. One more point is clinically also, you know, sometimes people know the echo report and they would have written bidirectional, you know, VSD bidirectional. I've seen students tell it in exam that it's bidirectional shunt. Don't do that. If you have to do bidirectional, you have to have evidence of bidirectionality clinically. So cyanosis is most of the time right to left, evidence of right to left shunt. But to have evidence of left to right shunt, you have to have LALV dilatation. Okay. So if you don't have LALV dilatation, do not use bidirectional in exam. Just because your expert has shown the echo report doesn't make it bidirectional. So go with the clinical findings and make the diagnosis. Next question.
Yeah. Kamlesh? Kamlesh, is there? Neither Deepanjan?
Yeah, this is acyanotic heart disease because femoral artery saturation is 96. Now we see the step up at the level of RA, and further RV is fine. A is also okay, pulmonary artery okay. Then RA pressure is 15, which is increased. RV pressure is also increased. So yeah, and LA pressure not mentioned. Okay. Aortic pressure is very like there is some AR must be there, so it could be a step up at RA because of and the RA pressure is also high. LA pressure not given.
No, white pulse pressure is not AR. White pulse pressure means any aorto, ventricular communication, aorto, ventricular or
Yes.
into the PE.
Diagnosis?
LV.
We discussed similar case before. Yeah.
RSO to RA.
Huge step up at RA with low diastolic aortic pressure.
RSOV, yes.
What?
RSOV
Two?
to RA.
RA.
Okay, so I have one question for you. This you know, shunt you can. What are obligatory shunts?
So the obligatory shunts are those shunts in which we require a systemic venous connection to maintain the pulmonary flow. Like we require a PDA or.
That may not be fully correct. There is obligatory versus what would be the opposite of obligatory shunt? So these are not, this is not English obligatory. English obligatory means obligatory for survival, no?
Yes.
It doesn't
Sir,
mean
obligatory
that.
shunt.
Obligatory shunt, it's not that shunt is needed for survival. That is not obligatory. Obligatory versus there is one more word. So what
The
are
obligatory shunts are those which shunt in a single direction irrespective of the pulmonary vascular resistance.
Very good. So they are not dependent on pulmonary vascular resistance and hence they will not Eisenmengerize. Okay. Since they are not dependent on pulmonary direction, it is going to be single, so it's not going to. Name some obligatory shunts.
The tricuspid atresia.
Yes, I was hoping with some left-right shunts, but yes, you're not wrong. Yeah.
In this case only, on the screen only, that's why it is being asked.
Yes.
Pulmonary atresia with PDA, sir.
No, see, again, you're going with shunts which are needed for survival, no? But that's not obligatory shunt. Obligatory shunts do not depend on pulmonary vascular resistance, okay? They're left-right shunts which do not depend on pulmonary vascular resistance. They will shunt left to right irrespective of PVR, hence they don't Eisenmengerize, okay? So what would be the example? Why am I asking it in first place? That's what Dr. Sumodh is telling you.
RSOV like this.
RSOV, yes, they don't Eisenmenger. What is the other example? Tell me at least one more example which you know very familiar.
Any VSD you know about?
Hmm.
It was shown before. One of the cases was that one.
We discussed the name of the defect also.
Yes,
It
Dr.
has
Sumodh's
to-
favorite. So don't forget.
Gassol's VSD.
No.
Gerbaud's defect.
Gassol's is a phenomena.
Gerbaud, yes.
Gerbaud, yes, very good. Gerbaud. Next one.
Danji, you can read. Danji?
Yes.
Yes, sir. I am audible.
Yes, sir.
In the femoral artery saturation is normal, so we are dealing with the acyanotic heart disease condition. SVC saturation is normal, IVC is normal. In the RA-RV, that almost it is normal saturation data. If we come to the pressure data, the pressure RA pressure is normal, RV is also normal. Pulmonary artery pressure, it is that is RV is connected to the PA and it is pressure is normal. Pulmonary artery wedge pressure is also normal. Pulmonary, then the LA pressure is slightly elevated with aortic pressure. That there is a wide pulse pressure in the aortic.
Huh? Wide pulse pressure?
Sorry, what was the diagnosis?
No, not at all. He's interpreting. Yeah.
Okay.
From there is a significant gradient between the aorta and the femoral artery of the systemic gradient. So it can be possibility of coarctation of aorta.
Correct. No? Any other differential?
It can be because of the that is aortoarteritis, which can lead to obstruction.
Yes, middle aortic syndrome. No?
Yes.
Any of them, anyway, level of obstruction is there possible. So any of them is possible. Yes. What do you, if you have to bet, what would it be? Coarctation. Coarct is very characteristic in the sense the diastolic BP also comes down in coarct. You know, most other stenosis, the diastolic remains the same between two chambers. Coarct is one where diastolic also comes down. That's why echo also you almost always see a continuous gradient in coarct. Most other, if you have subclavian stenosis, the systole changes, but the diastole may not change. So that is the characteristic of clot. The next one.
Sir, the LA pressure is high, sir. Why? Sorry, this RA pressure.
In this case,
Yes, sir.
yes, RA is high. It's the same case, is it? No, you're
No,
talking about
different.
the previous
Last
case, no?
one.
The earlier one.
No, no.
RA is just 6.
No, LA, sir. LA is high.
LA, yeah, LA will be high, no, because of hypertension.
LVDP raised.
There is
Okay,
high
sir.
hypertension, so LVEDP is high
Yeah, yes, true.
because of yeah. Okay, this one.
Sudhir?
I think this could be the last one, Dr. Mohit. We are beyond
Yeah.
this. I'm sure most people are getting bored.
No, not bored.
Sudhir is there? Sudhir?
Desaturation from aorta to femoral artery, sir. Significant desaturation.
Yes.
Seems to be okay. IVC, RA, RV, and PA are okay. And left-sided saturation are also okay, sir. So only significant point is symmetry data, saturation from aorta to femoral artery. In pressure data, sir, RA mean pressure is raised, sir. RV pressure and PA pressure both are raised. And in left-sided pressures, LA means is normal. LV, aorta, and femoral artery are normal, sir. So it seems to be a case with Eisenmenger.
Yes, and right to left shunt, no?
Right.
Yes, here see, whenever you want to think of PDA producing right to left shunt, make sure that the PA and the aortic pressure is same. Otherwise, it won't be right to left shunt. Okay, so it's like PDA with reversal of shunt and also produces reverse cyanosis. Okay, let's see the next one. Okay, example.
Ajay?
Sir. This is a pressure saturation, the SVC saturation, normal, RA, RV, pulmonary artery, all the saturations are okay. LA saturation normal, LV saturation normal, but the systemic arterial desaturation at the level of aorta and femoral artery. So okay, there's a systemic arterial desaturation in the saturation data. Coming to pressure data, RA normal, RV systolic pressure has been elevated, RV end diastolic pressure is slightly elevated, but PA pressure is normal and mean pressure is also normal. So there's significant systolic pressure gradient between RV to PA. Most likely that RVOT obstruction. Then coming to LA, the LA is normal. LV, the pressure data, LV, the systolic pressure is normal, end diastolic is normal, aortic pressure data is okay, 98 with the diastolic pressure 64, mean pressure. So I would like to tell
what is happening to
one, there is a significant RVOT obstruction at the level of RVOT obstruction with pressure with gradient of 70. Then with systemic artery desaturation, maybe the shunting of the blood at the shunting of a blood from left to right, right to left, most likely.
At which level?
Mostly that VSD outlet level most. Maybe top.
Top is fine.
Yes, look at the RV LV pressures, they are the same.
Yes,
you have your step down at LV to aorta.
And LV and RV pressures are equal. So both equalization of RV and LV pressure. So it may be a top physiology possible.
Yes, likely top, and it explains what Dr. Sumodh was telling. The step down is mainly at aortic level because of overriding of aorta. Now both LV and this will pump. So this the step down is predominantly at aortic level. That doesn't mean shunt is there. Shunt is actually at ventricular level. So
Okay.
Whenever you comment on RV pressure, always look at LV pressure. If they are
Yes, sir.
equal, there is likely to be a communication between these two chambers. Okay,
Yes, sir.
it's very classical TOF. The next one.
Okay. Kamlesh want to try? Deepanjan?
Yes, sir. The systemic saturation is normal, so it's an acyanotic heart disease. The SVC 68, RA 72, there's a significant step up of 20 from RA to RV, and the RV and PA are same, and there is no significant step down on the left-sided chambers. Coming to the pressures, the RA pressure is normal. There is the LV and the RV pressures are equal, and however, there is a significant gradient of around 77 between the RV to PA. So this appears to be a significant left to right shunt, then unrestricted VSD, and significant RV output tract obstruction.
So diagnosis?
VSD PS, TOF.
Yeah, but likely pink TOF. Understood,
TOF.
no? See,
Yes,
the point which we are trying to make, last example, this example. The pressure data is ditto, no? Same.
Yes, sir.
But the saturation data is totally different.
Yes, sir.
So it is a magnitude of RVOTO which decides whether the shunt is left to right or right to left. Okay. Pink
Yes,
TOFs are milder TOFs. Don't go by pressure. It's also the degree of this one. See, the gradient between RVPA also didn't change. So echo gradients don't matter. It's about systemic saturation which decides whether the TOF is severe or mild. Okay.
So, Dr.
So this
Shetty,
is
there is
pink
a
TOF.
simple question that often many examiners very clearly say that TOF by definition is always severe. So when we talk about pink TOFs, many of the fellows might, commit a mistake, or they say that it is a mild TOF. So some examiners are of the opinion that there is nothing called mild TOF. TOF by definition always is severe. So there is a reason that
no, not mild TOF, it is mild PS.
Mild PS, yeah.
Yes, by definition, it has to be a severe PS. TOF
Severe
by definition,
PH.
severe PS. So, what is the explanation they seek from students?
So degree of RVOT does vary even in TOF physiology, and best marker of that is systemic saturation. Can we have the next one? Yes, this is all different example just for you to understand the physiology. Okay, so just to understand that how same example, little bit here and there, the whole physiology changes. I think with this we'll stop. So whoever wants to diagnose.
Yeah, Pandey, you are taking it?
Yes, sir. We can see the saturation, systemic saturation is around 90, and there is a significant step up from RV to PA.
Okay.
And the saturation, the pressure of RV and LV are the same. So it is a non-restrictive VSD with step up at PA. So
yes, what's happening? What is the first diagnosis and what is the first step up at PA? No.
Yes, sir.
PS is not in doubt. VSD is not in doubt. Systemic desaturation 90 is not normal. No.
Normal.
So
yes,
some
sir.
sort of systemic saturation is not in doubt. So TOF is definite. TOF physiology is there. What is odd here is the PA saturation is not RV, but PA
Not
saturation
RV.
is higher. No.
Yes, sir.
So what are the possibilities? Why should the PA be higher? Is something naturally, Dr. Sumoda? Yeah.
What are additional, blood circulation that comes to PA in TOF, or whenever there is an RVT obstruction?
So there can be MAPCAs.
But do they come to PA?
No, sir.
Something similar to MAPCA?
MAPCAs are generally, they could be hilar, but they don't enter PA most of the time.
Yes, sir.
Even if they are hilar, no, they go inside.
Some shunt.
Some continuous murmur.
Yes.
PDA.
Continuous murmur, not machinery.
Post surgical shunt or PDA. Maybe.
Yeah, somebody answered it. Yeah, it could be PDA or it could be surgical shunt, no? BT
Yes,
shunt.
yes,
So it could be PDA or it could be. But one important message here, even though it is PDA, the murmur will not be machinery. It will only be continuous, because reason for machinery is the eddy current. So you know the PA flow jet plus one more jet. So here in the low flow situation, there could be a PDA, but there is no eddy current, you know, to the extent to produce machinery. So you'll get a continuous murmur almost like a MAPCA, even if it is a PDA. PDA can exist with TOF, no problem. What is very unusual with TOF? What is the condition which you don't expect with TOF? Anybody? Ajay, Dipanjan, anybody? With TOF, usually remember this, coarctation does not exist with TOF. Usually, you know, it's not impossible, but definitely becomes a case report, because RVOT, LVOT together is not unusual, with the exception. There are conditions where RVOT, LVOT exist together, but there are few. Most RVOT, either there is RVOT or LVOT. So coarct is unusual. PDA is not unusual. PDA can occur. Okay.
So there's a PDA which is causing a left right shunt from the aorta to the PA, small PDA, restrictive
Sorry?
PDA. So at the pressure, there's a restrictive PDA.
Yes.
Which is creating a left right shunt from the aorta to the coronary artery, causing the step up, but not much changing the pressure.
Yes, correct. That's the right explanation. Because the side, you know, the pressure is not gone up. It's definitely restrictive, but shunt and pressure may not go hand in hand. Okay. Yes. So shall we stop, Dr. Sumod, or?
Sir, one more thing.
Yeah.
In the TOF physiology, like when to commit like in TOF or like non-restrictive VSD with left to right shunt. You already discussed one slide. Just repeat, sir.
Okay. Non-restrictive VSD with left to right shunt. Huh?
Yes, sir. Yes.
You know, see, movement RV LV pressure is equal. It becomes non-restrictive VSD.
Okay,
along
sir.
with that, if you have PS, it becomes a TOF physiology. If you have a PS, RVOT along with that.
Okay, sir.
VSD decides the pressure difference between RV and LV, not the shunt, not the amount. So VSD decides. Okay. If there is PS, you call it either VSD, PS or TOF. If it is cyanotic, you will definitely call it TOF.
Okay.
So, Dr. Shetty,
yeah.
This is the last one?
Yes. I mean, there are 2-3 other slides. If you want, I can.
We can quickly wrap it up in a couple of minutes.
Yeah, we have a couple of minutes. Done,
just
done.
2 minutes, 3 minutes. We can.
Okay, we'll do it quickly. Next one.
Please.
Anybody?
Okay. Yeah. Again, Sudhir.
Quick answers, Sudhir and everybody. Yeah.
Quick answers. There are 23 slides. This is 21st. If we answer quick, we can finish all.
Whosoever wants to volunteer can go ahead. Yeah.
So there is no step up from the SVC to the RA to the RV or PA.
Yes.
Right side are same, pressure saturations are same. There is a significant step down from the LV to the aorta.
Okay.
And as we see, the RV pressures are similar to the LV pressure. So there's an unrestrictive, there's an unrestrictive VSD. The PA pressures are normal, so there is no PAH.
But what is there? No pH, but there is
mild increase of the PA pressure is there.
No, RV to PA there is a gradient.
Yes, sir. From RV to PA there's a gradient.
Yes, no.
Yes, sir. There is PS.
Diagnosis.
TOF.
Yeah. What is odd?
The LV pressure is 94.
No. What is this? Aortic pressure of 34.
The TOF with AR. Some.
Yeah. Or what else can be there? Why is the aortic pressure low? One is AR. What else can reduce aortic diastolic pressure?
Shunt. Diastolic run of shunt like RSOV or fistula.
No, but it's already a TOF. So we should talk about related to TOF.
MAPCA.
One is AR. Other possibility, there is a PDA or a MAPCA, no?
Yes.
Yes, sir.
Large MAPCA PDA can also produce the same thing. Okay. AR is definitely possible, but keep DD. Okay. Okay. 3-year-old with cyanosis, clinical diagnosis of TOF.
Sudhir is there. Dhanji?
Yes. In this, we are having the systemic desaturation. Coming with the SVC to RA, there is no, but venous saturations are quite very low in this. That is 47, 48, 45. There is no step up in the right side, but there is significant step down is there from LV to systemic, that is femoral artery. And in the pressure data, RA pressure, it is slightly elevated. The RV pressure, that is systemic pressure, is elevated, that is 120. And
diagnosis?
The odd point is that there's a dual step down from LA to LV and then from LV to femoral artery.
Which is
TGA,
okay,
sir,
no?
TGA.
That can happen.
TGA.
Yeah. Because
TGA.
RV is low, there is a bidirectionality there. But what is odd is, it's like top, but what is odd?
Pressure, sir, femoral artery pressure is 90/50. RV pressure is.
Hello.
The RA and LA pressures are like nearly same.
Disease is so severe that even PA pressures are not taken.
They're not able to enter PA. But problem is 120 and 90. See, that time it was 117. 10 is okay. There is a 30 gradient. So what's happening? Anybody? The VSD is getting restricted, no? By tricuspid reflex or, that's called Hoffman variant. But remember, Hoffman doesn't produce left to right. It produces right to left. They can become more sicker and more bluer. Okay. They don't become better. The VSD here restriction increases the RVOTO and increases RVH. So they have more right to left. Okay. Not left to right. Because the hallmark of TOF is anyway is RVOTO. The last one.
Okay, Dibanjan.
Yes, sir. There is a systemic desaturation. So we are dealing with a cyanotic heart disease. There is the SVC is very low, it's 56 only, and there is a 10% step up from RA to the RV, and again 11%, so 21% step up from the RV to the PA, with evidence of RVOT obstruction, and the RV pressures are suprasystemic, or the RV pressure is 95/10, whereas LV is 45/11, and aorta is 98/60. So there's a significant difference between LV and the aorta. And the LV saturation is similar to the PA saturation, and aorta is similar to the RV. So we are dealing with the case of TGA with PS.
TGA,
VSD, PS.
Is there a VSD?
These are the saturations are different. So, and the pressure
pressure,
different.
VSD pressure, no? Large VSD would have produced equal pressure between RV and LV. So here, the connection. Aorta, LV cannot be less than aorta, no? Aortic pressure matches the RV pressure. PA pressure and LV pressure, there's some gradient. So there is TGA and there is PS. But how do you pick up TGA? It's very important. First, look at aortic pressure and PA saturation. Any case where PA saturation is higher than aorta, you should think of transposition physiology, okay? When they are same, we call it admixture physiology. Every cyanotic, you need to look at PA also. As soon as you look at aorta, look at PA. If PA is higher, then it is transposition physiology. If PA is same, then it is admixture physiology. If PA is low, then it is likely TOF physiology. Okay?
Okay, sir.
in cyanotics. Okay. So if you see iota, I should go to PA. If it is higher like this, just by saturation, you know it is a transposition physiology. Other things follow very easily. Okay. Agreed?
Yes, sir.
Okay. And there is no VSD. Okay. Why no VSD? Then RV and LV pressure would be
And
equal.
pressures are different.
So this is a case of TGA. What about atrial communication? There is no VSD. Then you need either atrial communication or a PDA, no, to maintain it. There is too much dystemic C saturation. Pressures are same, but I don't know whether there is a communication because the mean pressure is probably the same, but we are not sure. Remember, if there is no VSD in TGA, it needs ASD as well as PDA. Okay, either single VSD is enough for connection, or it needs ASD as well as PDA. Okay.
Thank you. Thank you, Dr. Ranjan, so much. Thank you all our young fellows for participating in this. Thank you everybody for joining. We have around about 270 people live. Thank you, Dr. Sumod Kurian. Thank you, Dr. Safal. Thank you, Dr. Girish, and thank you, Dr. Arima, for joining. And thank you, Dr. Ranjan, for such a beautiful presentation, the question-based presentation. I think this will go a long way and will set the pace for youngsters to study. And we look forward to have the dynamics and the tracings in near future from you, and we'll be contacting you. Friends, if you have missed the earlier lecture also, you can go to our website or YouTube channel of PG Track CSI Delhi branch. And also you can mail if you have any questions to pgtrackcsi.delhibranch@gmail.com. Next week, we are going to come with a presentation on dyspnea and chest pain, all the questions that are asked in exam by Dr. Prabhavati from Jayadeva. So it will be a great presentation. I welcome you all to join on 9th Friday evening it will be. And thank you, Intas, for providing us this platform. We'll catch up next week. Thank you so much. Good evening and goodbye.
Bye. Thank you.
Thank you and good
Thank
night.
you.
Have a great weekend.
Good night. Yes.